Hello, my name is Omar Soubani. I'm a second-year resident at Wayne State University, Detroit Medical Center, and I'll be presenting this case that I worked on with my co-resident, Dr. Soka, and our attending, Dr. Saab. I chose this case because psychosomatics is one of the reasons that I got into psychiatry as a medical student, and it's something I really enjoy. Also, in the treatment of this patient, we worked with a lot of different fields of medicine, which was, first of all, a lot of fun and a very unique experience. So I'll start by presenting our 35-year-old female who presented with lower extremity pain and weakness that progressed to the inability to walk. She also had personality changes and weight loss with insomnia over the past 2 to 3 months. She was admitted to neurology and they performed a thorough physical exam. They found a lot of inconsistent findings that changed throughout her hospitalization and did not conform to known neural pathways. They took extensive labs, which I have outlined here in figure 2. These are just some of the labs taken, but the main point is that they're all contributory and they were very extensive. She received a lot of imaging, including a CT scan of her head, an MRI of her entire spine, which again was negative. One maneuver that we tried on her when we first assessed her was the Hoover maneuver, which is I have here in figure 1, where you flex the contralateral leg against the patient's resistance and you will find an involuntary extension of the paralyzed leg. Now, and that's a positive sign and that pushes you towards a diagnosis of conversion disorder, as opposed to if the leg was truly paralyzed, it would not have that involuntary extension. So psychiatry was eventually consulted and they found her to be disorganized, labile, and oriented only to herself. She was eventually admitted to the inpatient unit where we started her treatment. To discuss the treatment, there were 3 main modalities that we treated her with. First was pharmacology. Second was further history gathering and psychotherapy. And the third was physical therapy. So to start with pharmacology, when she arrived to the unit, she was noted to be stuporous and posturing and very withdrawn. So we performed an Ativan challenge, which was negative. She was soon started on Risperdal for the disorganized thinking and mood lability. That was eventually discontinued. And she was started on duloxetine for depression and anxiety, with the added benefit of treating the peripheral neuropathy that she had. This was titrated to 60 milligrams and she was discharged on that medication. As far as the history gathering and psychotherapy, she was found to have a lot of internal conflicts. I have them outlined here in the poster, but essentially she did have an occupational history of wheeling children to and from the bus stop and helping them get on and off the bus stop and wheeling them to their doctor's appointments. So the element of walking and wheelchair was very significant to her. She also had a lot of conflicts with her daughter that kind of rose during the COVID pandemic, which kicked off a lot of her symptoms. The last arm of this was physical therapy. So we consulted a physical therapist who was actually my roommate in college many years ago, and he saw the patient every single day. We started her off doing exercises in bed. She eventually progressed to a wheelchair and then a walker. Sometimes she would regress and want the wheelchair and refuse the walker. We had to hide the wheelchair. We took it away from her and made her only use the walker. By the time of discharge, she was able to walk the entire unit with the walker. Eventually, she was transferred to a subacute rehab unit. So as a discussion, I'd just like to outline a few things. First of all, conversion disorder has a lot of significance, historical significance in psychiatry. This young lady here is Anna O. She's one of Sigmund Freud's most famous patients, and she was said to have conversion disorder, and her care was said to be the start of the psychoanalytic approach. And speaking of the psychoanalytic approach, there's always keep in mind that in conversion disorder, the symptom has a symbolic relationship to the unconscious conflict, and with thorough history gathering, and you can attempt to uncover that conflict. Now, the main teaching point of this case is what I'm about to discuss. It's delivery of diagnosis. So a lot of times these patients are told by doctors, family members, friends that the symptom is all in their head, which further um, perpetuates the symptom and makes it very hard to treat. So we did a lot of research and came up with a way to deliver the diagnosis. And first we said that there was a definitive diagnosis, and we outlined all the steps that it took. So we said we went over the MRI, we went over the labs, we went over the physical exam findings, and we told her you have something called functional neurologic syndrome. And it's where your brain is working fine and your body is working fine, but the connection between them has been malfunctioning. We also introduced medicine this way by saying that, this medicine duloxetine will increase something called serotonin, which is a messenger that your mind makes and it sends to your body. So when you're on this medication, you have an increased amount of serotonin that will improve the communication between the two. We gave her a metaphor, to help her understand what was going on. We said that, hey, if you have a headache and we were to take an MRI, it wouldn't show anything, but you still have the headache. And she really, appreciated that one. So we went a step further and we said, just like a headache, stress makes it worse. So can you remember anything that's been stressing you out recently? And she was able to give a more meaningful history. So a quick word on treatment. All our research has said that everything works for conversion disorder, but the best way is a multidisciplinary approach with pharmacology to treat the underlying depression and anxiety, CBT and behavioral management, and physical therapy. Basically, get them up and moving. So that's what we did, and we eventually, like I said, transferred her to a subacute rehab, and that was the conclusion of our time with her. So I hope you enjoyed this presentation and you learned something for the next time you see somebody with conversion disorder. Good luck. Thank you.